Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel Riley. Welcome. We're in chapter 23. Yes. All right. We pick up page 354. Non-depolarizing muscle relaxants. A non-depolarizing muscle relaxant has its effect via the pharmacologic principle of competition among substances for the same receptor sites. When the myoneural junction concentration of the competing drug is higher than acetylcholine, the receptor sites will be mostly occupied by the competing drug, and depolarization of the muscle cell by acetylcholine will be blocked. As the relative concentrations of acetylcholine and competing drug change, the degree of muscle blockade also changes. D-tubocarini has been the traditional non-depolarizing drug of choice for maintenance of controlled ventilation. The initial curizing dose is often up to 30 milligrams and must be given only by a physician familiar with the drug, since it is a mild ganglionic blocker and may cause hypotension. Although reported to be associated with histamine release, this appears to be of little clinical significance. Maintenance doses of Curair are 3 to 9 milligrams and seldom cause hypotension. Therefore, it is reasonable to have intensive care nurses administer the maintenance doses of Curair, provided appropriate physiologic monitoring is available. Pancuronium bromide or pavulon is widely used in anesthesia as an improved non-depolarizing muscle relaxant and has gained great popularity in the field of respiratory care. The drug has a steroid base and is claimed to have certain advantages over Curair in that it is more rapid acting and does not have the ganglionic blocking side effects. However, tachycardia has been reported as a common side effect, which is very key whenever we see tachycardia involved, right? Because that's the heart rate. Peace. Hi, is heart love. Thank you so much for reading with us. All right, here we go. We're at the top of page 355. Yeah. The usual initial paralyzing dose of pavulon is approximately 5 milligrams in the average adult. Again, this must be given only by a physician familiar with the drug. Maintenance doses are zero point 0.5 to 1 milligram, and it is usually administered by the intensive care nurse. Pavulon is very similar in its clinical uses and clinical actions to that of Curair and has become the most commonly used non-depolarizing muscle relaxant. The non-depolarizing agents are reversible with acetylcholine. Oh, acetylcholine. Oh, acetylcholinesterase. Drugs such as indrophonium chloride or tenacycline, tenacycline or neostigmine or prostigmine. Reversal should be attempted only by physicians familiar with the process. Atropine sulfate is usually administered with the neostigmine to block its muscarinic effects. Muscarinic. It is generally believed that pavulon is somewhat more difficult to reverse after long-standing paralysis than is curare. In any case, the non-depolarizing agents are widely favored as the agents of choice for maintenance of muscle paralysis in ventilator care. Middle of page 355. Depolarizing muscle relaxants. A depolarizing muscle relaxant is a pharmacologic agent whose molecular structure is similar to that of acetylcholine, but which is not metabolized by true cholinesterase and which will attach to muscle cell wall receptor and cause depolarization. This depolarization is seen as muscle twitching or fasciculation shortly after injection. It takes approximately 3 to 10 minutes for an enzyme called pseudocholinesterase to metabolize the drug and allow the muscle to repolarize. Such a depolarizing muscle relaxant is succinylcholine or chloride anectine. Its onset is rapid, within 10 seconds. It is short acting and non reversible. It is used primarily for facilitating the intubation process and is seldom used for prolonged maintenance of ventilator care. Combinations of sedation and paralyzation are frequently needed and desirable. Certainly, as a conscious patient who must be paralyzed must also be sedated. To do otherwise would be inhumane. Yes, that's right. We want to give best chances of them healing without trauma. Maintaining bronchial hygiene. Yes, very key. Here we go. Bottom of page 355. Maintenance of a clear airway and removal of secretions from the tracheobronchial tree are essential in the care of all patients with tracheal intubations, especially the ventilator patient. The artificial airway results in the loss of an effective cough mechanism and ciliary function, potentially leading to pooling of secretions, right? Atelectasis and pneumonia. We have to get rid of those poolings of secretions. Any chance of it, right? It's part of the maintenance care. Respiratory and bronchial hygiene. All right, here we go. The three main techniques of assuring adequate bronchial hygiene are: one, proper humidification of the airway; two, positional rotation and aggressive chest physical therapy. Yes. CPT to prevent pooling of secretions. And three, proper suctioning of secretions from the airway. These techniques have been discussed in section 3. Acute segmental atelectasis is common during ventilator support and is best re-expanded by CPT techniques as previously described. See Chapter 12. All right. The fiber optic bronchoscope. Bronchoscopy bronchoscopy was considered the treatment of choice for atelectasis in acutely ill patients in the United States after World War II. By 1960, the advancement of respiratory therapy had incorporated the techniques of chest physical therapy, aerosol therapy, and IPPB therapy to re-expand atelectasis secondary to retain secretions in the ICU. These techniques proved far more efficient and less traumatic than rigid bronchoscopy, and thus respiratory care abandoned the use of bronchoscopy for bronchial hygiene in acutely ill patients. The fiber optic bronchoscope became readily available in intensive care in the early 1970s. This new technology allows visualization of the tracheobronchial tree without interruption of ventilation and with minimal risk to the critically ill patient. This new availability and relative safety of fiber optic bronchoscopy necessitates reevaluation of the role of bronchoscopy should play in maintaining bronchial hygiene in ventilator care. Diagnostic bronchoscopy is indicated when there is bleeding in the tracheobronchial tree or when there is question of tumor, secretions, obstruction, or foreign body. General therapeutic uses of bronchoscopy are suctioning, removal of foreign body, biopsy, and selective lavage. Some physicians prefer routine aggressive suctioning and lavage with the fiber optic bronchoscope rather than respiratory therapy techniques. Although it will take a period of years for the relative merits of fiber optic bronchoscopy versus chest physical therapy techniques to be documented, our impression is that the techniques of respiratory therapy, aerosol, IPPB, and CPT remain the first line of defense in the treatment of atelectasis from pooled secretions. Essential ventilator monitors. The prime concern of intensive care personnel administering ventilator support must be to eliminate any possibility of death due to mechanical failure or human error. Eliminating possible error. Very key. Let's put a pin right here. Ding! Yeah, that's what we want. Although there is no replacement for vigilant personnel, monitors to alert the respiratory care practitioner of possible mechanical failure or malfunction are essential. There we go. All right. Top of page 357. All ventilators should have a mechanism for measuring exhale tidal volumes. The gas volume exhaled into a spirometer is the best readily available reflection of the volume that has been delivered to the patient. It is not adequate to monitor only the volume of gas being delivered by the machine, since there is no guarantee that all of that gas will be delivered to the patient's pulmonary system. Measurement of exhaled tidal volume, ETV, is usually a reliable reflection of the patient's ventilation. Ideally, the exhale tidal volume spirometer should be readily visible. Visual and audio alarms should respond to disconnections as well as to significant decrease in exhaled tidal volumes. The monitor should have a reasonable delay mechanism, 15 to 20 seconds, so that it is not necessary to turn off the alarm for the suctioning process. An alarm system that must be routinely turned off is unacceptable since the human tendency is to forget to turn alarms back on. The audio alarm system should have its own battery power source so that it will be independent of electrical power failure. All right, middle of 357. Oxygen alarm. All ventilators must have a monitor to assure proper functioning of the oxygen delivery system. This does not delete the responsibility of the respiratory therapist to monitor oxygen concentrations of inspired gas on a routine basis. All right. Pressure relief mechanisms. The popularity of volume and time cycled machines makes it necessary to guarantee that excessive pressures will not be transmitted to the patient's airway. All such machines must have a safety pressure relief mechanism that will limit the pressure in the inspiratory line. This pop off mechanism should be accompanied by an audio alarm to notify personnel that excessive pressure is being encountered. Inspiratory line thermometer. A thermometer should be placed in the inspiratory line as close to the patient as possible to ensure that the gas is at or near body temperature. Superheated gas can cause hypothermia, and gas below body temperature will require heat and moisture from the patient's pulmonary system, resulting in a drying of the airways and crusting of the artificial airway. Thank you. Peace, YouTube. What's going on, y'all? We're in the 23rd chapter, page 358 of Clinical Application of Respiratory Care. Welcome to the peaceful part of YouTube where we read books and learn from masters. I'm Master Uriel Riley, Master Fitness Trainer. And hi, it's Heart Love. Thank you so much for being here and reading books with us. Much honor. Love to all the September birthday or October birthdays. We're coming around, right? Yes. All right. Top of page 358. Summary. A detailed discussion of all ventilator monitoring devices is beyond the scope of this text. It is incumbent upon the respiratory therapist to assure that the equipment is maintained in optimal working order and that all reasonable monitors are applied and functioning. The diligence of all personnel is required to assure patient safety. Some method of periodic systematic ventilator assessment is mandatory. It is of great assistance to establish some form of flow sheet system that requires a therapist to undergo a systemic check of the ventilator at least every 2 hours. All right. And inspiratory pause. Peace, hi, it's Heart Love, Crazy Kid, Caleb, much love. Thank you so much. Thank you, James Gary, for being here and reading books with us. Hi, it's Heart Love. Peace to all the light workers, all the intellects, all the book lovers community here on YouTube. Oh, we love you so much. Thank you so much. Yes, we're about to close out chapter 23. We did it again. We're doing it. No fear, right? When we live that way, that's how the Most High wants us to be. Walk with faith, not by sight. See all 360 degrees. And inspiratory pause. Inflation hold. The normal, spontaneous, inspiratory flow pattern has two characteristics believed to be significant in ensuring optimal peripheral distribution of gas. One, a gradual increase of peak flow. And two, nearly all of the inspiratory volume being delivered in the first half of inspiration. The gradual flow increase is believed to minimize turbulence and thereby enhances flow through the airways, although there is much theoretic debate concerning inspiratory flow patterns of ventilators, e.g., sine wave versus square wave. There is little evidence that makes a significant difference. The majority of modern ventilators begin inspiration with a square wave flow, a technical convenience that appears to be clinically acceptable. The delivery of volume in early inspiration is a matter that has received a great deal of attention in the past few years. With time cycled ventilators, it is relatively simple to deliver the inspiratory volume and then hold inspiration, delay expiration, and for an additional period. This an inspiratory pause or inflation hold, figure 23.1, capability appears to have significant clinical application. In simple terms, the longer the time from gas delivery to end inspiration, one, the greater will be the peripheral distribution of gas. See time constants. Greater, yes. Then we did that in chapter 3. Thank you all for who's taking notes also and replays and playlists. I will put the vocabulary in the um, in the details in the description when it's all uploaded. It will be there. Thank you so much for reading high level books with us here on YouTube. Sharpens the vocabulary, right? As well as it expands the wisdom and knowledge, right? And application of it gives us the healing properties that we want to give to the youth, right? We want to show them this early because once they know that they're reading something different, learning something different, they know it's possible to get better. Every day, I'm waking up. I'm going to get better. I'm going to have the best day. I'm going to learn some more. And that's that 360 degrees we're talking about. Right. Two, the better will be distribution of gas to areas of low V over Q due to regional airway resistance variance. Manual. Inflation hold has been utilized by anesthetists for 50 years to re-expand the retracted lung at the end of chest procedures. This principle was first applied in respiratory care following suctioning procedures to assure expansion of collapsed lung. Whether or not the naturally occurring yawn has a similar function is still being debated. However, Many investigators believe that the constant volume hypoventilation of the sleep state leads to miliary atelectasis that is re-expanded upon awakening by the natural inflation hold, the yawn. Wow. The pause. Let's go. Drop it there. Ding. The inspiratory pause. Sacred information and knowledge. Knowledge of self. Master thyself. All right, here we go. Figure 23.1, which is the schematic representation of the airway pressure curve with intermittent positive pressure ventilation, the IPPV, and inspiratory pause. The shaded area represents the inspiratory time following delivery of tidal volume, or the VT, to the airway. The rapid initial decrease in airway pressure is the result of significant flow from the upper airway to the lung. Note the pressure plateau that is maintained until expiration begins. This represents a significant period of time between the delivery of inspiratory gas and beginning of expiration, or a pause, right? And inspiratory pause. So here you go. You'll see the graph, and as it goes up, the bar is on the vertical bar. It is the pressure, centimeters H2O, right? And then the horizontal bar is the time. Page 359, Principles of Ventilation Maintenance, Chapter 23, Inspiratory Time and Expiratory Time. There you go. And you see the end inspiratory pause. There we go. Oh, we got a graph. Yay. Always love when we get to reinforce the information that we're reading with a graph or bar. All right. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition, 1979. Thank you so much for being here and reading with us. We're digging in. We're getting deep, right? All right. Love to you all. And inspiratory pause, inflation hold, is a useful and available airway pressure maneuver to provide optimal inspiratory alveolar distribution of gas with positive pressure ventilation. Tidal volumes between 10 and 20 milliliters kg delivered at flow rates allowing complete delivery in not less than zero point 0.5 second and not more than 1.5 seconds will result in almost identical mean airway pressures. With a ventilator rate of 10 per minute, 6-second frequency, and an inspiratory delivery time of 1 second, a 1 second inflation hold may be given and still maintain a 1 to 2 IE ratio, or 2 seconds to 4 seconds, right? Many clinicians prefer routine use of this airway maneuver. Inflation hold has its greatest potential clinically application in patients with significant airway resistance, although occasionally it may prove helpful in severe compliance disease. Expiratory retard. We're at page 360. Welcome, everyone. Peace, YouTube. Thank you so much for the likes and subs. We're pushing towards, wow, 600 on this channel. Thank you so much for the likes and the shares. Man, all the love, all the book lovers. Thank you so much. All right, here we go. Top of page 360 in the 23rd chapter of this wonderful, magical, powerful healing book. All right. Expiratory retard. Increased airway resistance is seldom the primary cause for acute respiratory failure requiring ventilator support. However, increased airway resistance is common in patients in need of ventilatory support for other reasons. This increased airway resistance is most commonly due to bronchospasm, pulmonary mucosal edema, bronchial inflammation, or combinations of these. Increased increased airway resistance results in an obstructive abnormality, i.e., the major problem is exhaling. Air trapping is common and may be accentuated on the ventilator since inspiratory gas delivery is greater than with spontaneous breathing. Thus, alveolar gas delivery during inspiration is enhanced, whereas expiratory flow may be impeded. The airway dynamics of a forced expiration in a normal individual is illustrated in figure 23.2. A when 23.2a. When exhalation begins, the intrapleural pressures increase due to abdominal pressure forcing the diaphragm upward. Right. How it goes. That's how it does. The alveolar gas is compressed by the positive intrapleural pressure and the elastic recoil forces of the lung, thus creating an alveolar pressure greater than the positive intrapleural pressure. Assuming 1. That the airways are subjected to the intrapleural pressures, and 2 that a gradual pressure decrease occurs from alveolus to mouth. Somewhere in the bronchial system, the intraluminal and extraluminal pressures will be equal. This theoretic point is called the equal pressure point, or EPP. Yes! Thank you so much. Peace, peace. What's going on? All the mods are in the building pushing flag. Peace. What's going on, Goddess Queen? Yes. Man, we're in the thick of it. 23. We're about to close out. Thank you so much for being here. Much love. Always great to see you. EPP, which is so big, right? The intraluminal pressures. The normal EPP is believed to be located somewhere above the small eye, where the airways possess reasonable skeletal rigidity and are not readily compressed or collapsed by increased extraluminal pressures. In our model, see figure 23.2, any phenomenon that decreases lung elastic recoil, e.g., acute alveolar distension or emphysema, will increase the difference between alveolar pressure and intrapleural pressure. During forced exhalation, see figure 23.2b, this would tend to move the EPP toward the alveolus, i.e., toward bronchioles that are potentially compressible and perhaps collapsible. Theoretically, this would tend to impede alveolar emptying during exhalation. The phenomenon is illustrated in figure 23.2a. A and B may occur in the absence of forced exhalation with positive pressure ventilation because the intrapleural pressures may be above atmospheric during exhalation. And here we go, 23-2 figure that what we're talking about. You see, there's a A, B, and C, and it's a schematic representation of forced exhalation. The shaded area represents the intrapleural space. A represents a normal lung. Note the air that intrapleural pressure is positive, +5, and the intra-alveolar pressure is +10. The airway pressure drop from alveolus to mouth is +10 to 0, is gradual. The intraluminal arrows represent the equal pressure point, or the EPP, and B represents forced exhalation with obstructive disease. All right. So, and C represents obstructive disease with retard. All right. C text 23-2. All right. We're closing out the chapter. Here it is. We're in the last page. Thank you so much for reading with us. Clinical application of respiratory care. As you see, A is healthy, B is with obstruction, and C full obstruction. Gratitude, peace, eyes on. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, Carole A. Trout, Yearbook Medical Publishers, 1979. We're on the 23rd chapter. Here we go. Last page. Technique of expiratory retard. The pressure drop resulting from a gas flowing through a tube with a fixed orifice will be related to the flow, the size of the tube, and the size of the orifice. If a restricted orifice is placed in the extrathoracic airway during exhalation, pressure along the airway will decrease less because the restriction acts to diminish the flow. This results in the maintenance of expiratory flow for a longer period of time. Thus, by placing a restricted orifice in the expiratory line of breathing circuit, figure 23.3, extraluminal airway pressures will be maintained at the higher level as long as expiratory flow is significant. This type of device is not used in patients with normal lung function, as it would needless retard flow during exhalation. All right, let me show you this before I close out. It's because it's at the end of the chapter. 23.3, figure 23.3, schematic representation of the expiratory limb of breathing circuit. A represents the exhalation valve in the open position. B represents a restricted orifice, and the restricted orifice will retard expiratory flow. See text. And 23.4 is a representation of the airway pressure curve resulting from positive pressure ventilation plus retard. The shaded area represents the increased airway pressure resulting from the retard. All right, here we go. I'm so grateful and thankful for every single one of you, all the book lovers and book readers community, all my mods and friends and family. Clinical application of respiratory care. We're doing it for the next generation. So they'll have it on free access. They can start to pick up the trade and the information early. And when we master thyself like this, studying anatomy, we can help our world be shaped by our thoughts, by what we put out there. And the more we focus, right? Focus energy vibrates high. So thank you so much for the likes and subs. So grateful and thankful for you. Peace, love, my love. Thank you. Here we go. Paradoxically, the function of the retard is severe obstructive disease is to improve expiratory flow by moving the equal pressure point. Since expiratory retard will maintain higher expiratory airway pressures while flow is present by increasing airway pressure in the trachea, the pressure difference from alveolus to trachea is less. See figure 23.2. C. Since intrapleural pressures have not been affected, the EPP is moved away from the alveolus. In most cases of severe obstruction, expiratory flow will be markedly improved when retard is appropriately applied. This principle is primarily applicable to patients with air trapping secondary to small airway resistance. It will not improve exhalation in a normal lung and may embarrass venous return by increasing mean airway pressure, which is figure 23.4. Pursed lip breathing is believed to be a form of retard exhalation. Expiratory resistance or retard on the ventilator may prove most beneficial when patients are undergoing acute air trapping secondary to small airways resistance. completion, completion of chapter 23. We did it! Page 363. Did it. Thank you so much, Queen Pushing Plant Based. What's up, Queen Clarice? Much love to you. Love to all the light workers, right? Love to all our friends and family. We do it. I love what you showed today on one of your reels. Oh my goodness. I mean, it's every time. I'm just like salivate. I'm like, okay, let me go get this and chop this up. Oh my goodness, you showed a way. Thank you so much. Highest heart love for all you do. Love to all the light workers. This is the peaceful part of YouTube where we read books and learn from masters. Give a shout out to the great Clarice Harper, pushing plant based, one of the great mods here. It's in the building. Love to all our friends and family that we have here with us and that we've lost on the way. We honor you. And this is why we do this. Keep shining the light every day, right? Outwork them. That's what it comes down to. Outwork them. The light workers, we outwork the hate. You know what I mean? They get tired of it. They just like, man, turn it off. What words is he saying? I put them in the description. You know what I mean? We keep shining that light, right? Gratitude, big gratitude. Thank you so much for saying that. Thank you for being here. Love you. Love to all that we've lost. We're grateful and thankful for all we have now and all that is coming to us. I love you. Mm. Mm. I love you. I love you. I love you. I love you. Glass of love water to the people. I'll see you soon when we reconvene going into chapter 24. Right? Oh, peace. Hi, love. Man, I'll see you. I'll see you. All right. I'll talk to you soon. Peace, peace. Yay. I love you. I love you. I'll see you soon. Peace.